the presence of the rectus femoris muscle, it prevents the proximal migration, as a result of which there is no shortening which is happening in case of anterior dislocation of the hip joint. So in anterior dislocation of the hip, there will be no shortening. Now the reason for this no shortening is rectus femoris. All right. The muscle which is present anterior to the hip joint, which prevents this proximal migration, is rectus femoris, and there will be no shortening associated with this anterior dislocation of the hip. Now, as far as management is concerned, again, the closed reduction has to be used, but the possibility of reduction achieved by closed method is lesser in case of anterior dislocation of the hip. So, first thing, you will try for closed reduction. So first you try for closed reduction, but majority of the time this closed reduction it fails, then you have to go for open reduction. Majority of the time open reduction is required, all right, for anterior dislocation of the hip joint. So hopefully everything is clear related to posterior and anterior dislocation, and how the questions are going to be formulated, and how you will identify based on the x-rays or based on the image of the patient provided to you. Now here what is happening in anterior dislocation, here the head of the femur is out of the acetabular cavity, but the thigh is kept into abduction and external rotation. So abduction external rotation is the attitude of the thigh. On the x-rays, as you can very clearly see that the head of this out of the acetabular cavity, but the thigh is abducted. So probably it is the anterior dislocation of the hip joint. Next comes the central dislocation of the hip. Now, under the heading of central dislocation of the hip joint, what all you need to remember are two facts only. Fact number one, in order for this hip joint to dislocate centrally, there has to be a displaced acetabular fracture. So it is always, this thing is always associated with displaced acetabular fractures, always. So this thing is always associated with the displaced acetabular fracture. When the acetabulum is completely fractured, so it will give a way for this head of the femur to get dislocated centrally. All right, point number one. Point number two, as far as the attitude is concerned, it will be fixed in abduction when the head moves into centrally. So to some extent it will be fixed in abduction, but that attitude can vary based upon the fracture site. So no one is going to ask you anything related to the attitude which is specific for the central dislocation. But yes, one clinical finding which is of significance is that on perrectal examination, the head of femur is palpable. All right. On the lateral perrectal examination, the head of the femur could be palpable. So this is one of the examination finding. Although because of the availability of the sophisticated investigation, this practice is almost obsolete. As an orthopedic surgeon, we do not go for perrectal examination more commonly, but this is a clinical finding which you have to remember as far as your examination or as far as your questions are concerned. So with this, we have completed hundreds and thousands of the questions are asked out of this topic in particular, posterior anterior dislocation of the hip joint. It is essentially important to you for you to remember at least this much out of this topic in particular. All right. Next topic is fracture head of the femur. Now, in fracture head of the femur, what all you need to remember is about the classification system. This question has been asked in 2012 examination, so it is important to have a discussion on the classification at least. So what is the classification for fracture head of the femur? The name of the classification is Pipkin, P-I-P-K-I-N, Pipkin classification. And Pipkin has classified the fracture head of the femur into 4 different types. So with the diagrammatic representation, we are going to talk about what the Pipkin classification is. All right. Now, this is, for example, the head of the femur. This is neck of femur. This is greater trochanter, lesser trochanter, and this is acetabulum. All right. We are talking about the fracture head of the femur. Now, all of you are aware of this fovea centralis. This is fovea centralis. All right, which is responsible for providing a way to the foveal ligament as well as foveal artery. Now, the fractures which we are going to talk about are related to this fovea centralis. Means the type 1 fracture of the head of the femur when the fracture is below the level of the, or involving the head of the femur below the level of fovea. So this is type 1, when there is an involvement of the head of the femur below the level of fovea. Then type 2 is when there is an involvement of the head of the femur above the level of fovea. So when the head of the femur is fractured above the level of fovea, it is considered to be type 2. The type 3 fracture would be transfoveal. That means involving the head, both the compartments. That means proximal as well as distal compartment. So it will be considered as type 3, transfoveal. And type 4th, the type 4th would be if there is a fracture head of femur, means anywhere in the head of femur if there is a fracture, but associated with this fracture, if there is a dislocation of the hip joint, means either there is a dislocation of the hip joint associated with the fracture, or there is a fracture neck of femur. Along with the head, there is a neck of femur fracture also. So as you can very clearly identify that the type 1 would be having the best prognostic outcome, while type 4th would be having the worst prognostic outcome. Whenever we talk about the classification system, it is all based upon the prognostic outcomes. All right. So type 1 below the level of fovea, type 2 above the level of fovea, type 3 is transfoveal, and type 4 is when there is a fracture head of the femur which could involve any region, but it is associated with either dislocation of the hip joint or fracture neck of femur. So that is type 4. Now, if you look at this this Pipkin's classification over here, now this is in the, if you look at the X-ray, there is a fracture which is involving infrafoveal head of the femur, but this is associated with posterior dislocation of the hip joint. So this is a type 4, Pipkin's type 4 fracture head of the femur, and it would be having the worst prognostic outcome because the possibility of avascular necrosis head of the femur would be relatively higher in these kind of the fractures. So at least this much you need to remember out of this particular topic, that is fracture head of the femur. Now comes the important topic, that is fracture neck of femur. You know, first of all, try to understand that where exactly this fracture is going to be in order to call it as a fracture neck of femur. Now, if we have a rough diagrammatic representation of the proximal part of the femur, so if this is acetabulum, this is head of the femur, neck of femur, and greater and lesser trochanters. So this is the area we are talking about. This much is the area we are talking about. That means fracture in the neck of femur. Now, these fracture neck of femur, instead of talking about the reason, the age group, the attitude, the presentation, the management, it is always important to have a discussion on the complications first, because everything would be related to the complication. Imagine if the patient comes to you with a fracture neck of femur, then the treatment would be decided based upon the possible complication the patient could be having. All right. The treatment, the management would be decided based upon the age group and the possible complications related to that age group in which the fracture neck of femur has happened. So everything is decided based on the possible outcomes in the form of a complication. So that is why before even talking about the classification systems, it is always important to have a discussion on the complications of the fracture neck of femur. So as far as the two important complications of fracture neck of femur are concerned, the first one is osteonecrosis head of the femur, which is considered to be the commonest complication. It is the most common complication. And the second one is non-union at the fracture site. Now, you know, they are asking that what are the reasons which are contributing to this non-union? Why non-union is such a common entity at the fracture neck of femur? Why most of the fractures at neck of femur, they go into non-union? All right. So there are reasons for this non-union. So if you remember, what are the reasons for non-union, increased non-union at the site of the fracture in fracture neck of femur? So the first reason is related to the vascularity. You know, fracture in the neck of femur or neck of femur or proximal aspect of the femur, including head of the femur, is relatively having a precarious vascularity, insufficient vascularity. All right. So first of the reason which is attributed is a precarious vascularity. That means insufficient vascularity. The second reason is the presence of enzyme which is hyaluronidase, and this enzyme, that is hyaluronidase enzyme, is responsible for breaking the clot it breaks the clot or hematoma. It is responsible for the dissolution of the clot or hematoma. That means hyaluronidase is present intracapsularly in the joint, which is responsible for breaking the clot or hematoma. Now, over a period of time, we will come to know that how this enzyme is responsible for contribution of the non-union. So remember, it is intracapsular enzyme. It is not present outside the joint. It is intracapsular all the time. And there is a reason why this kind of the enzymes are present intracapsularly. And the third reason is there will be absence of a cambium layer of the periosteum. You know, neck of femur, this neck of femur is devoid of the cambium periosteal layer. The neck of femur is devoid of cambium layer of the periosteum. There is no cambium layer of the periosteum which is present. You know, this cambium layer of the periosteum is responsible for the formation of the bone. It is responsible for contribution to the bone formation. And if the cambium or the inner layer of the periosteum is not present around any segment of the bone, that segment of the bone is at a disadvantage. Because if it is broken, then it is not getting any help from that cambium layer if it would have been present at the site. So that is another reason. So that means there is no cambium layer of the periosteum. Now, before we talk about this enzyme, hyaluronidase, how is it responsible for causing non-union? It is always important to have a discussion on what are the stages of fracture healing. So let's have a discussion on the stages of fracture healing. You know, this fracture healing can be of two types, the primary or a secondary type. A primary type of a fracture healing is where you attain a compression at the site of the fracture, where there is a formation of the bone by the osteoclastic activity. First, there will be osteoclastic resolution and then there will be osteoblastic formation of the bone. So it is a creation of the bone in the form of a cut and cones. So that is a primary type of fracture healing. But what is the natural aspect of the fracture healing is attained by the secondary type, where there will be a bridge formation, there will be a callus formation around the fractured end, and over a period of time, these two ends of the bones, it will unite through the process of ossification. So stages of fracture healing, we will be talking about the secondary, that means fracture healing by secondary intention. So what are the stages in this fracture healing? The first stage is the stage of hematoma formation. The second stage is the stage of granulation or inflammation. You know, granulation is a part of inflammation, so this can also be written as a stage of inflammation. The third is the stage of callus formation. And you know, it is important to have a discussion of this callus stage because, you know, callus is the first sign of fracture healing. It is considered to be the first sign